Hello, this is Dr. Scott Hoy. Thanks for listening to the Psychology Talk podcast. Kyle and I are on break for the summer, but we've been selecting archived episodes that we find are relevant and interesting. So we hope you enjoy this Encore episode of the podcast formerly known as the Chicago Psychology Podcast.
Cognitive processing therapy is a way to help kind of bring that prefrontal cortex back online. They've actually found in some studies that even, just looking at pictures can bring that prefrontal cortex online. And so there's this idea that even just talking about the trauma, that actually starts to kind of change how the brain responds to trauma reminders. It starts to slow down that process. It helps to kind of quiet the amygdala.
Hello, I'm Kyle Miller, licensed clinical professional counselor. In this episode, I will be talking with Dr. April Crawford. Dr. Crawford is a licensed clinical psychologist with Chicago Center for Growth and Change. Dr. Crawford specializes in working with people who have suffered trauma and uses a technique called cognitive processing therapy, or CPT. Dr. Crawford and I discuss what brought her into the field of psychology and the history and effectiveness of CPT. I learned a lot in this interview, and we hope you do as well. Thank you for joining us. Thank you for joining us at the Chicago Psychology Podcast. Today I'll be speaking to April Crawford, clinical psychologist at the Chicago Center for Growth and Change. Hi, April.
Good morning.
How are you today?
I'm good. How about yourself?
Good. Thanks for asking. We're glad to have you on. So we're going to be talking about CPT. I know what CBT stands for. What does CPT stand for?
So CPT stands for Cognitive Processing Therapy, and it falls under the umbrella of cognitive behavioral therapy, but it's a specific cognitive behavioral therapy for PTSD.
Oh, Okay, great. Well, that was a really good explanation. I'm very clear now. So what we like to do at the beginning of our interviews is to get a little bit of background about you. If you could, would you be willing to tell us, what you did before you became a clinical psychologist, or before you started working at the Chicago Center for Growth and Change?
Yeah, absolutely. If it's all right with you, my story kind of dates back into high school, so I can start there.
That's great.
Okay. So my interest in psychology was actually peaked in high school. I was fortunate enough to be going to a high school that offered a extracurricular class in psychology, just kind of general psych. And I really enjoyed that class. We focused a lot on individual behaviors and individual theories for people's behaviors in that course. But I also was able to take a sociology class. And so I was torn between psychology and sociology for the first, couple of years through high school and college. My interest in sociology, I think, was around kind of the same idea about being curious about people's behaviors, but it was more focused on groups. And my interest continued into college, where I went to the University of Illinois at Chicago. I ultimately decided to get my psychology degree and then got a minor in sociology. So people's individual behavior is interesting to me in the fact that sometimes it didn't make a whole lot of sense why people were doing what they were doing, at least on the surface level. And psychology, at least the theories behind it, gave me some kind of ideas about what could have been going on. And so the same kind of concept for sociology about why do groups interact this way. I think some of that humorously was connected to teenage angst and not understanding why is the world the way that it is, why are people the way that they are. And so at the University of Illinois at Chicago, they had a class that was specifically for applied psychology. So I got to volunteer on a crisis hotline for about a year. In high school, I also did some hands-on work volunteering at a hospital, just kind of helping get people from different rooms. And also did that for a little bit at the assisted living homes, and realized I didn't really want to go too heavy into the medical side of things, was more interested in people's psychological experiences. And with having that In Touch crisis hotline experience, it just kind of solidified for me that I wanted to do more of the hands-on clinical work. And so I ended up choosing psychology over sociology because I wanted to have more of that deeper relationship, deeper connection with people.
Okay. And so I'm assuming that that you are a quote unquote scholar. Is that is that what led you to going all the way to psychologist, or was that always the thought for you?
There was a brief moment where I had considered majoring in art, but I didn't think that I had the skill set to make a substantial amount of living, and wasn't willing to work a side job while doing an art gig.
Okay.
So
that's cool.
I decided I would do psychology, and then I could do art on the side. That might be more lucrative for me.
Does just for my curiosity, are you still dabbling in art? Is that still a part of you?
I like to draw. I think took a little bit of a break from it in graduate school with all of the homework and all of the reading. I kind of fell off for a little bit, but I've been trying to get back into it. My significant other has been trying to push us to get a draft table so I can put my art supplies up.
Okay. And is that something that, do you ever incorporate that into any of your sessions?
I don't. At least not now. For one of my training rotations in graduate school, I did do some work with children, and there was more of an opportunity when I was working with children and adolescents for art to be a part of how they express their feelings and their thoughts in session. I had people that would bring in drawings. We'd talk about what that meant for them. So that was a way to connect with the younger population. Sure. I'd be open to it with my adult population, but it seems to come up less frequently. Yeah,
absolutely. Okay. So you had, there was a thought that maybe you would try something else, but the two sides, art and psychology kind of were, it seems like they carried about the same weight, and you chose psychology. Okay.
Yes. In undergrad, I also did an undergraduate internship at a state psychiatric hospital, and I was supervised by the recreational art therapist, and so I got to explore that a little bit. Really enjoyed it. We did a lot of art projects as part of the therapeutic work there. Due to the nature of inpatient psychiatric hospitalization at this point in time, they're typically limited art projects or short-term based. There's an opportunity to talk about some life situations, some life stressors, but we weren't really able to go deep into their emotional experience the way that I wanted to. And so I thought that talk therapy would be a better realm for me to operate in.
So that was, that kind of leads to my next question was, I saw when I read your bio that you have some experience working in a hospital. And so how did you get to moving into private practice?
So I did in graduate school a diagnostic training at another state hospital for a while. Really enjoyed that. And then I did therapy at a rape crisis center for one of my training rotations, and then did another training rotation at an outpatient clinic that was attached to a hospital, and also did a round of doing emergency room psychological assessments. So I'd always been kind of tied with the hospital route and continued to pursue that for my internship. So for my internship, I actually worked on an inpatient unit at an adult psychiatric unit. Did about a year there, and then did another year and a half of postdoc on the same inpatient psychiatric unit. And at that point in time, I had realized that I wanted to be able to keep the connection for a longer period of time than what I had been getting when I was working on the inpatient units, in comparison to the outpatient settings. And so I ultimately ended up making the decision to try to switch to go back to outpatient so that I could have these longer relationships. The majority of the people that I saw when working in inpatient units and when working at these psychiatric hospitals had a trauma history. And so that was something that had remained consistent from undergrad to graduate school to postdoctoral training. It was this interest in trauma. And when I decided to take the job in the outpatient clinic, the hospital that I was doing my postdoctoral training at, one of the colleagues that I was working with was actually providing some cognitive processing therapy to her clients. So that's kind of where it took off with CPT for me.
Okay. So you had experience with another clinician, and so that built up your interest in it? Okay.
Yes. I had always had an interest in trauma, but I never felt like I was ever able to make significant movement with people on the inpatient setting. We were able to start the conversation about it and to look at how maybe that might be impacting their experiences, but we were never able to really dig deep into it. I think part of my concern was that I didn't want to start that conversation in the hospital and then not have them be able to continue that when they left. And it wasn't always certain that was going to be able to happen for people right away.
So you didn't want to open the door and then just have this person who has started dealing with their trauma and then walk out the hospital door and not have that support. Yeah.
Right.
Yeah, I can understand that.
Sometimes there's a lag in starting outpatient therapy after hospitalization. People don't always follow up. So
yeah,
I got to see a lot of the start of people's mental health treatment, start of the change, but I wanted to be there for when that ended, when they were transitioning into this healthier part of their life.
Right.
And so outpatient was where I could see that.
Okay. And it sounds like it's almost like you were in the realm of putting out fires and you wanted to move into, long-term growth. Yeah.
Yes.
Yeah. That makes sense. I mean, I could imagine that would be, I never actually had personal experience in a hospital. So, but that sounds like it would be a little daunting over a long period of time to only get to see the beginnings of people's movement. Yeah.
Yes. Yeah.
Okay.
And the atmosphere is definitely different too.
Oh, I'm sure. Yes. Okay. So you kind of led into talking about CPT. I'd be interested. So the modalities that you typically subscribe by, do you call yourself a cognitive behavioral therapist?
No, my training is from the Illinois School of Professional Psychology. I got my doctorate degree in psychology with a generalist training background.
Okay.
A lot of my coursework was heavy into diversity, multiculturalism. I was always interested in trauma, but didn't necessarily get a specialization with that. And I wanted that after graduate school, and cognitive processing therapy seemed to be a way for me to start to build my niche in that area. I think just professional career development wise, that was something that I was beginning to become concerned about after I graduated. I wanted something to help set me apart. Wanted some more specialized skills. And so cognitive processing therapy just seemed like a good fit since this interest in trauma had been consistent for all these years.
Mm-hmm. Okay. So tell me about CPT. Can you give us a little bit of an overview of it? It's somewhat new to me. I'm familiar with cognitive behavioral therapy. So can you kind of walk us through it?
Absolutely. So cognitive processing therapy has been around for more than 25 years at this point. So the treatment authors are Patricia Rezick, Kate Shard, Candace Monson. They worked together to come up with this treatment that uses a lot of cognitive behavioral theory, but is geared towards specifically treating PTSD. At the time that it was starting, the idea for cognitive processing therapy was starting, there were very few rape crisis centers in the U.S. So this was around like the mid-1970s. And the research and material about rape and people's experiences with that was kind of limited. A lot of the articles were missing certain parts of that experience. Some of the sociology research had some victim blaming language. So treatment for rape victims and rape survivors was, I think, still in the early stages. At least that's my impression. Okay. So at the time, the theories about responses that people were having about rape was based on kind of this first order conditioning of a fear reaction. Right? So you have a neutral event, and then you have this traumatic event that happens, and the person makes this association with that kind of neutral event, that fear response. Those things get connected. And then they talked about second order conditioning, where then that fear response starts to get kind of generalized to other neutral stimuli that's connected to that original neutral stimuli that happened with the traumatic event. And then that leads to other kind of triggers for trauma reactions. Then when people started to talk about PTSD, then we started to have some of those theories about escape and avoidance, and learning these escape and avoidance tactics that unfortunately maintain the PTSD, even though they offer temporary relief. So there's a lot of talk about fear networks and how things get, these neutral kind of experiences start to get paired with a fear response because of that traumatic event, and it starts to get generalized. There was also, at that time, people were trying to have a better understanding about the role of depression in post-traumatic stress disorder. So in regards to rape victims and rape survivors, they were talking about this idea of learned helplessness, how these negative interpersonal events, these threatening events, and, obviously that experience can have a pretty heavy blow to someone's self-esteem, how that starts to impact their belief system, how they think about themselves, think about these other areas in life. So all of that is going on. And then you have Aaron Beck in the 1960s and 1970s, who is talking about cognitive theory, how people learn these negative beliefs from society or from their experiences as they grow up, and how that contributes to depression. And so he'd come up with a manual for depression. And so CPT borrows from some of that, but it's really, I think, born out of a lot of different theories that are kind of put together to really provide this holistic treatment for trauma survivors. So it's looking at the fear response, it's looking at the avoidance, the escape, it's looking at people's thoughts and beliefs and how they're shifted from the trauma. with cognitive processing therapy, there's a skills building portion, and then there's also kind of these more intensive sessions where you're looking at people's belief systems around safety and trust and power and control, esteem and intimacy. And I think the reason for that is there was also at the time this idea of the constructivist self-development theory of traumatic victimization. And so how people's schemas in those different areas or their beliefs in those different areas get impacted by the trauma, how they make meaning out of that. So,
okay.
Yeah. There's a lot of different things.
I mean, it definitely, that helps me to understand more of the history of it and how it works. I'd be interested to hear, I know that it's a very structured form of therapy, and I've listened to it was on NPR's This American Life. There was an episode called 10 Sessions, and you got to be in the room at times, and then you get to hear from the clinician and all of that. So I'm kind of interested to hear what your experience has been like using it, and how it's if you can kind of walk me through what it looks like for you in practice, and how you without going into too much detail, but like just talking about the general results that you're seeing from it.
Absolutely. So when I meet with people, I usually take about 1 to 3 sessions to do an in-depth assessment about PTSD to rule out anything else that might be going on. So really the first step for me is trying to figure out if CPT is going to be something that this person wants to do. Okay. Cognitive processing therapy can also be used for people that have kind of a sub-threshold level of trauma. So maybe they don't meet the full criteria for PTSD, but they meet the majority of it. The piece I think that's really important with cognitive processing therapy for me when I'm making a decision about whether or not to offer it to somebody is what kind of traumatic event we're talking about. So cognitive processing therapy is helpful and more geared towards treating trauma related to sexual abuse, physical abuse, kind of natural disasters.
Mm-hmm. Kind of single event?
It can be for multiple. That's the wonderful thing, I think, about this. You can do this with someone who has one trauma. You can do this for someone who has multiple traumas, but they have to kind of meet that criterion A of PTSD, or it has to be a particular type of trauma. Okay. So if someone comes in and they have a history of emotional abuse, and understandably that's traumatic for them, but they don't have any of the other types of abuse that I talked about earlier, I probably wouldn't offer this as a treatment for them.
Okay.
So after the assessment, and I'll use things like the PCL-5, which is a trauma measure that looks at the different symptom clusters for PTSD. Mm-hmm. If they meet criteria for PTSD or meet the subthreshold criteria for it, then I'll go ahead and offer that as an option to them. The first session of cognitive processing therapy is mainly educational. So I'm talking to the person about what is PTSD, what are the different experiences that they might have, trying to explain it to them without using a lot of the psychological jargon, but giving them a vocabulary for it if they so choose. Mm-hmm. So with that session, I'm talking about the symptoms. I'm talking about how PTSD is maintained through that avoidance and escape piece. Mm-hmm. And then also talking to them about the role of emotions in PTSD. So The analogy a lot of times that I like to use is a pop bottle. So you have this traumatic event that shakes the bottle up, and understandably there's this desire to shove that cap on so that that bottle doesn't explode. You don't have this really uncomfortable experience. But with not allowing that pressure to come out without really looking at the feelings that you're having or the beliefs that you're having, and how they've changed or been impacted by the trauma, you never get this chance to really relearn or to make sense of it. So that pressure just stays in there. And so that's kind of how I try to explain that to people.
Okay.
I do a little bit of a talk about the biology piece, about how with PTSD, the prefrontal cortex, the part of our brain that really looks at kind of critical thinking and executive functioning, that starts to kind of turn off, and the amygdala, the fight or flight responses, those things are kind of stronger. And that cognitive processing therapy is a way to help kind of bring that prefrontal cortex back online. And they've actually found in some studies that even, just looking at pictures can bring that prefrontal cortex online. And so there's this idea that even just talking about the trauma, that actually starts to kind of change how the brain responds to trauma reminders. It starts to slow down that process. It helps to kind of quiet the amygdala.
Right. When I went through training around trauma, it was the prevailing thought was the more that you talk about it, the more that the brain is able to process it, and it eventually works its way through. And it sounds like that's some of what you're talking about is you're processing it in a safe space, and that allows your brain to process it and the body to calm. Okay.
Yeah. So in a way, that's cognitive processing's therapy exposure component, right? So you have these other treatments for PTSD, like prolonged exposure, and EMDR. I think the talking about the trauma and the talking about your beliefs about the trauma is a way to expose yourself to those uncomfortable feelings, to those thoughts. And I think it's just a different way to kind of relearn or to make sense of the trauma. For myself personally, I was drawn towards cognitive processing therapy because if I was going to pick a trauma treatment, this would be the one that I would be more apt to choose. Okay. So I think personally I have a preference for it. And so that for me, that makes it a good fit to be the delivery.
Absolutely.
So that first session, what I ask the person to do is to write an impact statement. And so that's their homework for the week. And there's homework every week throughout this entire therapy. Okay. In that impact statement, I'm asking them to talk about why they think the trauma happened. So we start looking at the beliefs behind what factors they think played a role in that. And then also to talk about how the trauma has impacted their belief in these different areas of safety and trust, power and control, esteem and intimacy, not only in regards to themselves, but also in regards to other people. Right? So how much do you trust yourself, your own judgment? How much do you trust other people? How safe do you feel with yourself? How comfortable are you being by yourself? How comfortable are you with other people? Those kinds of things. And so from that, then in the second session when we meet, it gives us an opportunity to really start to look at what this person's stuck points are, what their beliefs are that are keeping them from having experiences with other people, or that are keeping them back from being able to function in their day-to-day life. the other piece that happens in the second session is also there is some processing of the feelings behind PTSD, and what their personal feelings are about the trauma. So there is this opportunity to process a little bit about their emotional experience.
Okay.
And then sessions 3 through about 6 usually are focused on cognitive skills. And so it builds on each session. So in session 2 and 3, we're just trying to help the person be able to make the connection between their thoughts and their feelings about different situations that come up. And then it starts to become more focused in on their trauma-related beliefs.
Okay. So you just talked about sessions 3 through 6. How many are there total? Is it?
So on average, there's 12 to 15, but it can go up to 24 depending on the client's cognitive abilities, or there's been times where I've extended treatment because there's more than one trauma that, so I think maybe that would be something that would be helpful for me to talk about, is that with the impact statement, the person is picking the trauma that's causing them the most intrusive symptoms, and we focus in on that. And the idea is that if they learn the skills to be able to manage the trauma that's causing them the most distress, then that should be able then to apply to the other traumas.
Okay, that makes sense.
So,
okay. So after session 6, what's happening there?
So from session 6 to 12, we're having a more in-depth discussion about their beliefs about safety, trust, power and control, esteem, and intimacy. And so there's one session for each of those, where we delve deeper into their beliefs in those different areas, and then continue to use the skills that they have learned through sessions 2 through 6 with those particular beliefs.
Okay. And so tell me, how have you seen this working in your practice? What have you seen as far as the impact that CPT is having on your clients or patients?
I've seen a dramatic shift for the majority of the people that I've worked with. This is a treatment that works for a lot of people, not everybody. But for the majority of the people that I've worked with, I've seen their symptoms come down by at least 50%. There's usually a significant drop that happens somewhere between session 1 and 6. Not always. When it doesn't drop by session 6, I'll often revisit with people if there maybe might be another trauma that we're not talking about that we need to.
Okay.
And having a discussion about how avoidance can keep PTSD alive, and if there's something that's maybe been hard to talk about that maybe we need to, if maybe, we need to pick a different trauma to focus on. Maybe we originally thought that the initial trauma we picked was the one that was causing the most distress, but we find out later that it's not. There's this other trauma that happened. It's causing a lot of the symptoms, and we'll make a shift to that. And I'll have them redo an impact statement for that particular trauma.
Okay.
That can go a couple different ways. Some people want to write it. Sometimes, I'm able to just do kind of a verbal impact statement with the person. But typically there's a pretty significant shift. The other thing that I'll talk with people about if we're not seeing a big shift is if there's some of these assimilated beliefs about the trauma. So a lot of times the assimilated beliefs are around things like self-blame, things I should have done this, or if I did that, then the trauma would have happened. It's my fault. Those kinds of beliefs.
Right.
And if those So those are typically the first set of beliefs that I will work with people on, because typically what I'll see is that if we can really work on those and get the person to a place where they can have a more balanced view about why the trauma occurred, then all of those over-accommodated beliefs will follow suit, and the person will start to be able to challenge those and believe in those less. So,
okay. So let me ask you this. If, let's say you don't see that growth between sessions 3 and 6, and I guess, have you ever run into a situation where someone has been reluctant to go into, or maybe hasn't been able to access another trauma that they've experienced? How would you adapt therapy to support them?
So I haven't had that happen yet, but I'm sure that will happen at some point in the future.
So we can brainstorm.
Yes. If that were to happen, I think I would want to have a discussion with them about, are there beliefs that we're not looking at that we need to? But I would also have a discussion with them about what other things could be playing a role. So as I've mentioned earlier, there's homework assignments from week to week. And so typically these homework assignments can take people anywhere from 15 minutes to an hour, depending on what belief they're trying to work on at that time. And this is, I think, true for a lot of therapies. The amount of work that you put in makes a big difference for what your outcome is going to be. And so, we might be having a discussion about what's going on with the homework. We might look at how consistently homework has been done, if they're doing it every day, or if this is something that's been getting crammed into one day before the session. So to give a little clarity about that, with the homework assignments, they'll get certain cognitive skills that they have to work on a daily basis. And so that gives them practice with those cognitive skills. And so if you're doing it more routinely, you're getting more proficient at using it. Mm-hmm. It doesn't work as well if you're doing it for one day in a week. Ideally, that would be something that I would be gauging throughout therapy to make sure that it's happening every day. But I would still want to have a conversation with them at session 6 about, how have you been doing the homework? Is there something that we need to change about that? Is there something that, are there pieces of the homework that maybe aren't making a lot of sense? Also having a discussion with them about, is this the right treatment for you? Because it may not be. It works for a lot of people, but not everyone. Mm-hmm.
So someone who isn't either interested or in the space to do that homework on a consistent basis, it might not be the right treatment.
Right.
Yeah. So if they're not in that space yet, they've got some other work to do before they may take this approach, or another form of therapy might be a better fit for them. Mm-hmm. Okay.
Yeah. So for this therapy, I mean, it's a lot of work. It's hard work. It can be painful. It can have really good payoffs, but you have to be willing to talk about how the trauma has really impacted how you think about yourself and other people in the world. And you have to be in a space where you can make time to do the homework every day. If that's not there, it's going to be really hard to get the benefits of the treatment. And so that's something that I will also have a discussion with people about during those assessment sessions between, session 1 and 3 before I offer CBT. but is this a good time for you? Mm-hmm. Are you going to be able to come in on a weekly basis for the next 12 to 15 weeks? If someone's going on a vacation for a month and a half in the middle of treatment, they're likely to not get the same kinds of results.
Right.
So that might not be a good time. Yeah.
That sounds like it might be true of any approach, right? If you're going to be missing a month between sessions. So as you were talking, it just makes me think that there's a kind of a heavy cognitive load in this work. Mm-hmm. And now I'm thinking back to what I did here in the podcast that I listened to. There's a lot of time, it sounds like, between sessions, sitting with yourself and really working through some of that homework. It sounded like, a lot of writing, or at least a lot of thought about it, and taking mm-hmm. down notes and kind of going back through that and bringing that back to the next session.
Right.
Yeah. Yeah. So
there has to be a willingness to talk about your homework and to share it.
Right.
So that's part of that exposure piece, not avoiding the trauma by talking about it, by doing the homework.
Right. Yeah. And it's that going inward. Okay. I feel like I have a really a more clear sense of what CPT is now. So that was really helpful. I appreciate your insights.
A couple of things to keep in mind. So cognitive processing therapy is for adults. So the person has to be 18 years or older, ideally. 4th grade formal education. There are some adapted worksheets in the manual if somebody needs a different kind of format. It's kind of, I guess in some ways, kind of a more simplified or different way to kind of think about the worksheets. They offer some adapted versions for people that maybe might need a different format for them.
Okay.
Yeah.
So are you saying maybe people who can't handle the cognitive load, maybe they need a little bit adapted? Okay.
Yes. If the person has an IQ of 75, they can do it. It's not recommended for someone who has lower than 75.
So you make the determination on whether you use those adapted worksheets or not.
Yeah. So, I mean, ideally it would be something that I would offer to the person if they were telling me, like, I'm not getting this, I don't understand. I might bring out the adapted worksheets and go, well, how about if we look at it this way? Okay. Does this make more sense? And then say yes, then we switch to that. So,
okay. That makes sense. So is there anything else that you think we need to know about CPT?
I think one of the things to consider is comorbid mm-hmm. issues. Cognitive processing therapy can be used for people that have other mood disorders. If the depression is so severe that the person's not able to leave their house or they're not able to take care of their...
is there anything going on that you want to let our audience know about you or your practice? So do you have anything any upcoming events, anything about the Chicago Center for Growth and Change that you'd like us to know?
Yeah, so we are located in the Loop. We're on the corner of Michigan and Randolph, and so easily accessible for a lot of people in the city. We offer services for children, families, and adults, and we offer an array of treatment for PTSD. So we have myself, I provide cognitive processing therapy services while getting consultation from a certified cognitive processing therapist out in Seattle. And then another one of our providers offers EMDR. And then we have another provider that provides prolonged exposure. So we have a wide range, treatment options for PTSD. I think something else that kind of helps to, that we're really proud of, we also have psychodrama groups that we offer. Yeah, so that's I think a different kind of avenue that can be explored for someone who wants to kind of go at their mental health issues in maybe a different way than purely talk therapy. It involves action methods that let the group members express their feelings, the safe environment where they can reenact and kind of explore different events in their life. So that's really cool that we've got that.
Yeah, that's really cool. Okay. Anything else that you'd like to share with us?
One of the other services that we also offer is trauma-focused CBT, and that tends to be used for children and adolescents that have experienced traumatic events. And we also offer some Gottman couples therapy.
Okay, that's good. That's good to know. Okay. Well, April, it's been my pleasure. I really have enjoyed this conversation, and like I said, I've learned a lot more about CPT from hearing you talk about it. And I really thank you for coming on and sharing your experiences with us.
Thank you for having me. It's been a pleasure talking with you.
Thank you again for joining us on the Chicago Psychology Podcast. This podcast is for entertainment and informative purposes only. If you need a mental health professional, please seek one out. We hope you enjoyed today's show. All material copyright 2019 by the Chicago Psychology Podcast. Music provided by the band Serenati.